Hello everybody. My dear friends, colleagues, the world is full of surprises after, I would say, a most interesting day on very challenging topics. I see so many people here. I thought there would be 5 or 6 people still interested in talk about septal perforations, and I see that this is what I would call a full house. People are still coming in. I'm really surprised that so many people are interested in my personal experience in how we deal with nasal septal perforations. So it will be, I would say, a personal talk. It will be based on the experience that I have now for 25 years. I got this as an heritage from Professor Austin, who in those times was doing that kind of surgery, and at a certain moment he said, "Mark, I want you to take it over. This is the way I do it. Find it out yourself." I must say that if you look at what is known about nasal septal perforations, I don't have to explain you what a nasal septal perforation is. You all are aware of that. I think everybody knows quite a lot about septal perforations, but we also know that it is rather difficult to deal with and that our patients are not always that happy. And that there has been not really a very high scientific interest in the field, because if you look at what has been published, and this is the period starting in 1950, this is 1956, and you see how many hits there are in all those years, and you say that this is a topic, maybe quite a lot of people do it, but they do not publish about it, and if people do not publish about it, that already says quite a number of things. And also, if you will, afterwards we'll see what the results are, then there is definitely, I would say, some room for improvement. Now, having said that there is not that much interest in the field is in contradiction with somebody who is here in the audience, and as I saw, I immediately said, well, he can better come to the stairs and he can better talk about it. And this is what I would call a fantastic work, and as you are all interested in the field, I would say you should all buy this book. If you want to know more about septal perforations, it's a book written by Isam Alobit with the help of Paulo Castelnuovo. He is over there. So I say, Isam, you should bring tomorrow something like 200 copies of it, and they will be sold immediately, I would say. Now, this is really a very good book. I just got it from a resident we sent to him, and she came back with the story about it, and I must say that the book has been read by many people in our department already. I would say thank you for having the idea, thank you for working it out, and thank you for publishing. I think it is a great thing for our clinical practice. So if we're talking about septal perforations, we're talking about, I would say, necrosis, we're talking about vasculature, and so what you should know, certainly when you have to deal with the septal perforation, you really should know about the vasculature, but I think most of you should know about it, and this is a slide that I got via Laura from Isam, and he knows, of course, it. What you're dealing with is the anterior ethmoidal artery, and if you will look at recent evolutions in there, there is really a major role of the anterior ethmoidal artery in the closure of septal perforations. You also have the posterior ethmoidal artery, as you can imagine, it's located over here and over there. And then, of course, you have the sphenopalatine artery with the different branches, as well to the turbinates, as well to the nasal septum. And this is one which is also very important. Now, if you're dealing with septal perforations, of course, the first thing that you have to ask yourself, what's the reason? What's the cause of the septal perforation? I think this question is always crucial before going to surgery. And the reason why I say this is that because there is one, I would say, really major issue in there, and the issue in there is the cocaine. We see a number of guys and girls with septal perforations, and you ask the question, well, is there any cocaine use in the past? No. Never used it. And you ask it again, and you look into the nose, and you see a septal perforation. It looks a little bit ischemic. It is really dry, and you ask again the question on any cocaine used? No, never used cocaine. What is it? You get answers like that. And I would say, based on recent experience, never trust your patient. And the reason why I'm saying this is that if you're going for surgery in a nasal septal perforation, and you do it in a patient which is still using cocaine, this is a disaster. So never treat a patient who is on cocaine, I would say. And there are a number of ways, and I will come to that, but I find it that important that I will say it immediately. There are two ways that you can check it. One is, of course, you take a urine sample and you do an analysis of cocaine. You should be there, I would say, when the patient is delivering the urine sample, because otherwise they will trick you, they will not give you the right, I would say. And that will give you some idea about, I would say, recent use of cocaine. But what I have been using now a couple of times is to do a hair analysis. And that's very simple. It is not that expensive. I think it's something like €100 that the patient has to pay. But I ask for a 6-month sample of outgrowing hair, meaning you go from the skull and you take 6 centimeters. And what I normally do, I see the patient and I say, well, maybe you have been using it during the last months. That is not an issue for me. But I will see you back in 6 months. And your hair should be at least 6 centimeters long. Right? And then they come back and then we take a sample of 6 centimeters. And that is analyzed. And I make a deal with the patient. If there's any cocaine found in there, you get out. And I don't want to see you back, because it is of no use in trying to treat you when you're still using cocaine. We got one patient, and the nurse did something wrong. She took not only the last, I would say, 6 centimeters, but she also took between 6 months and 12 months. And it turned out that between 6 and 12 months, which is the period before she came to the consultation, the result was positive. But the last 6 months, between the first and the second consultation, were negative. And I said, well, okay, you have shown your goodwill, so we will plan to do the surgery. Patient, of course, still has to wait for a couple of months before we go for the surgery. The surgery was a success. Patient is no longer using any cocaine, and after everything was fine, I said, you don't have to come back anymore, because there's nothing that I can do. I can look at your nasal septum and say everything is okay, but you don't need to come to our hospital every 6 months or so. I have other things to do. But she is so happy about the whole process and decision that has been taken that she's really coming back every year to show me her nasal septum. Okay. But I say that also because recently we had an example, a patient who had a trauma, who had a septal correction. Because of that so-called septal perforation, we tried to close a septal perforation, which was not a success. Patient came for surgery again. We did the surgery. The surgery was a disaster at the very long term. And the member of the staff who was seeing the patient said, now I want to have a urine sample of you, and the sample was positive. We should have done the procedure before, because then we would have found that the patient was still using cocaine, although he completely said, he always said he has never been using any cocaine. And the two disasters would have been no disasters, because you would have said to the patient, well, still using cocaine? No surgery. You don't have to come back anymore. And that for me is so important. And I think if you really get something home, it's not the cocaine, but the fact that you have to check your patients with a nasal septal perforation for using cocaine. But you all know that most of the perforations luckily have nothing to do with the abuse of cocaine, but are more, I would say, traumatic. You do a septal surgery and the healing process is not okay, and you end up with a septal perforation, and that's it. Closing the septal perforation then afterwards is somewhat more difficult, certainly if the first surgeon has been what I would say more radical. Other issues, of course, there can be chemical exposures, as you can see here, chemical irritants, physical irritants. If you are exposed to chrome salts, then of course you have a high risk of getting nasal septal perforation. Not only that, you also have to you have to look into your patient for systemic disease, which is, I think, quite evident. Whenever that you have a patient and the mucosa does not look healthy, please check for systemic disease. And if there is systemic disease, please do not go for surgery, because any surgery that you will do in an active systemic disease is going to be a disaster. We know that also from sinus surgery, for instance, in people with Wegener's granulomatosis and things like that. Of course, there are also a number of infectious diseases that would luckily in our Western countries we do not see quite a lot. And then, of course, you always have to take into account the fact that the septal perforation could be the sign of a tumor, could be the sign of a malignant process. So, but that's something, as you can see, you will also find in the book that you will buy tomorrow from ISIAN, and otherwise you send him an email and he will arrange it, and otherwise you send the email to me and I will make an arrangement with ISIAN for all the copies that he has been sold. Okay. Cocaine, this is, I would say, some facts and some figures. According to me, what is the most essential part of this is that it is underestimated as a cause of nasal septal perforation. And so there are quite a number of patients where you do not have immediately an explanation for the septal perforation. Please check this. What is important is that if you would take a CT scan of a patient with cocaine abuse, you will see the septal perforation, and for the rest the sinuses seem clear. It gives an ischemic necrosis. It does not really give inflammation. So if you take a CT scan, you see the septal perforation and you also see inflammation in the paranasal sinuses, this is unlikely to be a cocaine-induced pathology. This is more likely to be something related, for instance, to another systemic disease like Wegener's granulomatosis. It is mimicking it, but so what I would say the difference, how you can make the differential diagnosis without a cocaine test, of course, is looking at the sinuses. In Wegener, you will find inflammation. In cocaine, you will not really find the inflammation. Okay, that's something that we have said. So the laboratory test, of course, also in cocaine you can have some positivity of tests which are, I would say, more related to Wegener granulomatosis. But as I said, the most important element here, and this for me is not, this is really the very advanced stage, but normally because here you also have a perforation of the hard palate. But you will get very destructive lesions without really quite a lot of inflammation in there. Should you take a biopsy? I think that you have to take a biopsy whenever there is any doubt about the cause of the disease. And if you take a biopsy, you should take it, of course, there where there is disease. That means that you should not take the necrotic area, but there where you do have inflammation, that's the place where you do have to take a biopsy. And the reason why you're taking the biopsy is, I would say, not really to make the diagnosis of the inflammatory disease, because for that you will also have the blood analysis, but certainly to rule out the malignancy, for instance, a lethal midline granuloma, a natural killer cell lymphoma. Those are things that can mimic, or that can really resemble. Okay, this I would say I will leave to the issue on the diagnostic evaluation. Of course, what you also have to do is measure septal perforation, and being the head of a university department, I always say to my residents that you have to measure a septal perforation and you have to note it. It's always surprising and astonishing and disappointing if you see in how many cases there is a note about a septal perforation. It is more or less described where it is located, but the dimension anterior, posterior, and superior, inferior are not mentioned. And I think it is relevant because if you see a patient and at a certain moment you take the decision for going for surgery, you should have an idea about the evolution of the dimensions of the septal perforation. So what I will present to you is a retrospective analysis which has not been done by myself. I did the surgery. Only cases that I have done have been selected, but the analysis has been done by a resident and a younger staff member. I said to them, these are the files, you do the analysis and you come back with me with the results. I don't want to interfere anyhow with anything that you do. I have to accept it. I think this is the only way that we can be honest and that we can share with you results which are valid and that you can maybe use in your practice. So all of them have been done, I would say, using the same technique. In the beginning, I have been using quite a number of techniques, and at a certain moment, I abandoned a number of them. So first I did it in a closed rhinoplasty approach. I abandoned it because I had a number of negative experiences. I found that I could not really make the flaps the way that I wanted to do, so I didn't do that any longer. I have done transposition flaps from one to the other, quite a number of things, and then finally I found that I had the best results, so 15 years ago, with the external rhinoplasty procedure, and then making bilateral flaps, and then making them completely superiorly and inferiorly. I will explain it in a minute. And then trying to closure the gap without tension on the mucosa, and then in most of the cases transferring some cartilage from posterior to anterior, so there to fill in the defect that you have in the cartilage. And that's basically the technique that I have been using. And I must say we have great success, but we also have failures. And I think that if you will also take home the fact that there are failures and that maybe you can prevent failures, and for that you need other techniques, or maybe there are other things that you can use, then I would say I would be very happy about that. So it all has been an external rhinoplasty approach, which is, I would say, a very standard procedure. So you start with the reti incision, you go bilateral marginal incisions. Then I would say I do the exposure of the caudal end of the septum, and in a number of cases, luckily not that many, there is no caudal end of the septum anymore. That's one thing that you do. Then you go under the dorsum, and then you start to prepare your flaps. Yeah, I have to use this one. Okay. Then what we will do is that we will prepare the tunnels. I would first start under the dorsum, so I will go look for the most anterior superior portion of the quadrangular cartilage, and so go just underneath the nasal bones, and then go more posteriorly and inferiorly, at that moment still leaving the septal perforation as it is. The next thing that I will do is then I will go downwards, look for the anterior nasal spine, look for the premaxilla area, and then go further on, making what you could call an inferior tunnel. At that moment, if possible, still leaving the nasal septal perforation margins intact. Once that we have done that, then I will incise it, and it is depending on how the borders of the septal perforation are, whether I will do a debridement of the edges. If you have some scar tissue over there, then I would excise it, because if you're going to stitch mucosa to mucosa and what you're doing is scar tissue to scar tissue, then at least I think that you will not have a very good healing process afterwards. So once we have opened up the septal perforation itself, we will make the 360 degrees of the free edge of the perforation, and by that, of course, then you have access to the superior tunnel above the perforation, you have access to the inferior tunnel below the perforation, and then as you do in classical septal surgery, you will make the connection between the two, so that you have also have access to the posterior part of the nasal septum, specifically the posterior border of the quadrangular cartilage, which may go up to the rostrum sphenoidale. Once that we have done that, so at that moment you have, I would say, done classical septal preparation with the margins completely freed. And then I think the most important part of the surgery is over there. We will do it superiorly, and we will go under the triangular cartilage and under the nasal bones, and by that you can go up to about 1 centimeter. You can do a preparation on the lateral nasal wall, just under the dorsum. You can make a preparation of the lateral part, and then, of course, if you know something about tissue handling, then if you free there about, I would say, 7 millimeters, then you have the superior tunnel, which is over here. You have the preparation of the lateral wall, and then what you can do is bring this down by the angulation of where you really have freed the mucosa on the lateral nasal wall under the triangular cartilage and the nasal bones. And by that, of course, you can let descend the mucosa of the perforation downwards, and there you can mobilize, I would say, rather easily up to 1 centimeter. If you had a perforation of 1 centimeter, then you can mobilize the septal mucosa down 1 centimeter, means that you have already, so to say, closed the septal perforation. The same procedure is then done on the floor of the nasal cavity. So you have your inferior tunnel, you go over the floor of the nasal cavity, and you go laterally up until the attachment of the inferior turbinate. By having done that, you also have freed quite a lot of mucosa, so that the mucosa of the septum can then be lifted up without really tension. And if you would not have enough, of course, you can also make some relaxing incisions. Relaxing incisions, which you can do on two sides. You could do it under the at the level of the triangular cartilage and the nasal bones, which is so that you can mobilize the superior flap a little bit further on, but you will gain much more by doing a relaxing incision under the attachment of the inferior turbinate over the lateral nasal wall, so that you can mobilize the mucosa of the lateral nasal wall, the floor of the nose, and then the nasal septum, and mobilize it towards superiorly, at least on the septum. Once that we have done that, so we will also, as I said already, harvest the cartilage posteriorly and then place that more anteriorly. Regarding the inferior part, you have to take care of the fact that there is the incisivus, the artery and the nerve, and that by completely mobilizing that, you will have a problem. It can bleed a little bit, but certainly the patient will have problems with the sensitivity of the front teeth at that site, and that may last until 6 months after the surgical procedure. Until now, I have never had a case where it was permanent and that the problem persisted. So, but this is something that you have to know in advance, and you have to warn your patient about it. So that has been said. And then I would say the most important part of the surgical procedure is done. What we will do then is, first of all, I will try to suture without tension both sides of the septal perforation. And by that, normally we will put 3 to 4 sutures, depending, of course, on how big the perforation is. I always try to do the first suture posteriorly and then come anteriorly, because that's the most difficult one, the one that you will put most posteriorly. And if you leave that till the very end, it sometimes becomes very difficult to do the manipulation in the nasal cavity. What I also do is that I will separately suture both sides of the perforation. So the left side will be sutured on the left side, of course, and the right on the right side. And there will be, I will not try to close the gap by placing a matras suture from left to right and then coming back. So I'll do it separately on both sides. We have done the suturing, then we do the graft placement in between, and then we will put some silicone sheets in there, which is material which is about, I would say, 0.5 millimeter thick, that you easily can buy, that we try to adapt to the size of the nose at the inside, of course, which is rather hard plastic, I must say. I think that in the future we will use something which is softer than the one that we are using now. They will be sutured then with a matras suture, so that you have everything in place over there, and we will leave that suturing and so the silicone sheets in there for 2 weeks. The Miracell packing will be put in place for 1 week, and then of course you still have to do the closing of it. So the patient will have a completely blocked nose during 1 week, and it takes 2 weeks before we will take out the silicone sheets. And normally, if everything goes right at that moment, then you have already a good result with the septal perforation closed without tension, but of course suturing still in place, and that I would leave in place until I'm rather confident about the final result. So this is graph representation of what we do. Just in memory, this is something that I will not do. What I will do is that I will mobilize it over here and then come back down to that level, and then this mucosa will be mobilized and bring down. This is something that we on a number of occasions will do. So we will mobilize the inferior tunnel, the floor of the nose, and then going up until the attachment of the inferior turbinate, and there we will make an horizontal incision, and by that making it possible to, I would say, transpose the mucosa upwards, at least at the level of the nasal septum. The cuts over here in my series, I think maybe I did it once, but certainly not more. And the stitches are put, as you can see here, and as you can see. But what we always try to do also is to put some cartilage in between as support and as supplementary division within the septal perforation reconstruction. In most of the cases, we still have enough material within the nasal septum so that we can use the cartilage within the nasal septum, and that's then the most posterior part of it. In a number of cases, the extension towards the sphenoidal sinus. In 1 out of 4, conchal cartilage has been used, and in very extensive cases, we have used a combination, or you say, I take conchal cartilage and I do not feel really confident, and there is still some septum in there, so I will use that also as transposition support. These are the results that this is some of the patient information. 40, you can say it's about 50% female or male. If you look at the size of the perforation, here you see that this is what I would also like, namely that it is really measured and that you fill it in your patient chart. You can see that there are small perforations in about 1 out of 3. This is small to medium size, namely less than 2 centimeters as the maximum diameter of the perforation, in about 2 out of 5. And then you have the largest one, and as always, as I said, in a number of cases, this is not noted. So we do not know, or really do not know, it is not noted how big that the size is. This is where they are located, and there should be something more. So most of them, of course, are anteriorly located. And this is, I would say, very easy to explain, because if a patient has a perforation over there, he is not going to complain about it. And of course, we will only be dealing with perforations the patient is complaining about. If somebody has an perforation at the level of the vomer, most of them do not complain about it. There are even people with a congenital aplasia of the vomer. I've seen it 2 times. I must say these people do not complain about anything at all. So if you do have a posterior perforation, in most of the cases you do not have to deal with it. And of course we will only treat patients who do complain. And what I haven't said yet, but I should mention it, of course, if a patient has problems with a septal perforation, the first thing that you will do is to try with conservative measures, ointments, and things like that, to see whether you can control the situation like that. And it's only in those who still persist, who still have problems, or who do have recurrent epistaxis and things like that, that we will go for the surgery. There's also quite a lot to do about septal button placement. I did it in the beginning of my career a number of times, and I must say I have not very good experience with placement of nasal septal buttons. Most of the ones that have been placed by me or by my co-workers or other members of the staff have been taken out after, I would say, some time. And there has been an evolution in there that with 3D printing, of course, you can also in soft material make a really individualized septal button, and maybe that will offer more comfort to the patient. But it will, I would say, it will never be the final solution to the septal perforation. So most of them are located anteriorly, which is, I think, quite evident. Would not be wise to do something which is posteriorly. If we look at the ones at the causes of the perforation, then in most of the cases, I would say this is a trauma. And if you can see, we have 6 patients in which there was cocaine abuse. Of course, as I said, we always try to avoid it, and will refuse to do surgery on a patient who has been using cocaine during the last months. If you look at the traumatic cases, then here you can see what has been done. In most of the cases, I would say, this is because of a rhinoseptoplasty, even multiple surgeries, things like that. I think you're all aware of that. There is nothing special, there is nothing new in that. The patient characteristics, of course, they will are symptomatic. It's not just because there is a perforation that you will go for surgery. But of course, in a certain amount of patients, you can only have whistling, and whistling can be, I would say, very annoying for the patient, not only for the patient, but also for the environment. Okay. And you should know that most of the symptoms are present when you have a perforation between 10 and 20 millimeters. Now, if you look at our results, and these have, my resident has been very severe because she said that if there is still some notice of a mucosal defect, there is still a risk that this is going to open, and so she said, I will classify them separately. And that turns out that if you look at the results, then they're certainly not perfect. Personally, I'm convinced that most of these have been gone out of a follow-up because everything turned out to be right. But of course, I have not contacted all of these patients individually afterwards, so I cannot claim that. So, are there failures? Of course, there are failures. There are a number of patients in which afterwards we had no good result. There was still a perforation present. But what I think is important, and this is also a message that we can give to our patients, that if you look at the ones which are technically the failures, namely you do have afterwards a recurrence of the septal perforation, I would say I can claim that all of them had less problems than they had before the surgery. And even about half of them had no problems at all anymore. They still had a perforation, but in those cases, one, the perforation was much smaller and was located more posteriorly and more superiorly, and because of that, they had no problems with it. And then, of course, you can ask yourself, is this then a success or is it still a failure? Because the final goal is, of course, that you have a patient who is happy, a patient who is symptom-free. And if about half of the so-called failures, the patient says afterwards that everything is okay, then we also have to take that into account. Now, of course, and you can imagine that the larger the perforation is, the higher the risk is that you will have a failure. And certainly, if the septal perforation is more than 2 centimeters, I have to admit that I have learned my lesson, and that during the last years I will be very reluctant to use this technique for going for the closure of septal perforation. And if you look into other textbooks, into other articles, then you will find, I would say, the same conclusion. And the essential thing about it is that, of course, at that moment you have to consider, what am I going to do? I'm here confronted with a septal perforation of 2 centimeters, maybe a little bit higher, a bit larger. Am I going to use the technique as I explained to you, or am I going to use another technique? And I think that the answer to that is, well, certainly I think it would be wise to use another technique then, and I think there are quite a number of people who would agree with it. So I'm almost at the end of my presentation, so there will be still some time for questions and discussion. What I think also is important, and this is something which is really, I would say, new, which is based on an experience that we had in a patient with a septal perforation, but a complete destruction, I would say, of the nose, the inferior turbinates part of the bone of the maxilla, where we did do debridement, and it didn't heal well. And then I got information about the possible use of LPRF, which is leukocyte plasma enriched fibrin. You take a blood sample, you centrifuge it during 10 minutes, I think it's 800 RPM, and then you get a clot, a white clot, that you put on some metal so that it can shrink and that the liquid can come out, and that what you end up is so-called a membrane which is very rich in leukocytes, in growth factors, in blood platelets, and this is something which is very good for the healing process. And as I had wonderful success in that patient with destruction because of cocaine, that within 2 weeks there was a completely re-epithelialization. We have now been using this also as an additive, as an add-on on the closure of the mucosal layers in septal perforation, but we do not have enough data on that to give results on that. But I know that very recently there were already publications on the use of the LPRF membranes in reconstruction of the skull base, so I'm quite confident that in the very end this will help also. And that brings me, I would say, to my next slide. If you do the surgery and you do not know what to do, then of course those who really have very good eyes can see that what you need is the book of Isam Alobit, because there you will find all the solutions. I'm not going to really comment on all the flaps that have been described, based, I would say, most of them on the anterior ethmoidal artery, but there are many other flaps. I think you can go home, buy the book and read them all, and you will be very confident the next time that you will be confronted with the patient with a, I would say, symptomatic septal perforation, and you think that you can help him. I thank you for your attention. You are a wonderful, attentive audience, and maybe there are questions. But it has been a very busy day, so I can imagine everybody wants to take a shower.